All right, so today we'll be talking about the incision and drainage of a simple abscess. A patient presents in your clinic with pus-filled cavity under the skin. The main reason it's going to bring them in is it hurts. It's painful. It could be attributed to many different things, but an indication for actually incision and drainage of this abscess in the clinic would be an abscess that is larger than 5 centimeters, an abscess that is fluctuant, an abscess that has been refractory to conservative treatment, cellulitis, febrile, and most certainly pain. If the abscess is less than 5 centimeters, typically they can resolve it at home with just warm soaks or things of that nature. Indications when you would not do an incision and drainage in the office would be if the abscess was extremely large and it required like an extensive incision, debridement, or irrigation. Abscesses in sensitive areas that would require a general anesthesia to actually sedate the patient. An abscess in the palmar space or in a deep plantar space would not be optimum to be done in the clinic. Abscesses in places like the nasolabial folds, which could drain into the sphenoid sinus, or if a patient is on anticoagulants, which is a relative contraindication. So, what can happen from this procedure as far as like complicated measures? For one, there will always be a scar left. After this procedure is done, the patient will have a scar. This could lead to cellulitis. It could lead to a fever. The incision or the infection could actually spread from where it is to another region of the body after the incision and drainage is done if the loculations are not all removed. So what do I need to actually do this? I need my PPE materials. Before I actually adorn the PPE, I will have explained to the patient what the procedure is, explain to them the complications, explain to them the indications for why we're doing this, explain the necessary follow-up for this, and I will have then obtained informed consent from the patient. Now, what do I need to do it? I need my PPE. I got to have gloves, and I need to have eyewear because these things can splash sometimes. I need to first numb the area up. I will do that with a 10 cc syringe filled with 1% lidocaine with epi with a 25 gauge needle on the end. I will first prep the skin, okay? I'll prep the skin with just using a simple like betadine solution. We're just going to try to make it as sterile as possible to minimize infection. So what I'll do first is I will just do a little field block here, putting the 10 cc's of epinephrine on the edges of the wound. What I'm doing is I am just numbing this up so that whenever I make the incision, it will be less painful for the patient. You will tell them up front that this incision here will be painful, but it is okay. So now that we have numbed the patient up, we will put our needle to the side. This takes about 5 minutes to actually set in. But in the interest of time, we'll pretend that it's been 5 minutes. I will touch the incision, asking the patient if they feel this. When they say that they do not, I will then take an 11 scalpel blade and I will make an incision right here in the middle of the abscess. And as you can see, it will start to drain. Now that I have made that incision, I will carry it out the length of the abscess, and there it all starts to come out. Okay? Let it drain spontaneously on its own for a few minutes. Take some gauze, and then we'll just start working this out. Getting all of this fluid out of the abscess. Sometimes this will be accompanied by a foul smell. That is okay. We're getting it all out. Okay? Once we do that, we'll continue to get more. We will take our curved Kellys here, and we will open this up to break up potential loculations that are still in the wound. While we're here, just to rule out infections, we will send a culture to the lab. So here, we've got a specimen. That goes to the lab for culture. Breaking it up. So following this, once we feel like we have, sufficiently got all of the abscess out, we will then, once we feel like we've gotten all of the pus out, we will then irrigate the abscess with a saline solution. Okay? And then we'll still be soaking that up. All right, from there, we need to pack this wound. So we'll take our materials here, and we will begin to pack the wound. All right, just as so, putting the packing in with our curved Kellys. So right here to the side, put the packing in. Now, the follow-up care for this is very important because we will need to tell the patient that they must come back to the clinic in 2 to 3 days to have this packing removed and to check the healing of the wound. What this is doing is healing by a secondary intention. The wound will heal from the bottom up, and that is what we're letting the patient know. So they'll come back in 2 to 3 days to assess the wound. We will have sent the culture off to see if there is any infection. If there is, antibiotics can be prescribed. At the time, there's no indication to give antibiotics prophylactically because that is just simply not necessary. That pretty much wraps up the incision and drainage. Before we send them home, after we've explained to it, we will put a sterile bandage over the packing. We'll ask them not to remove it. We'll trim this right here, and we'll see them back in 2 to 3 days.